My name is Dr. Cyrus, and today I'll be talking about a glimpse into the rare disease landscape of Barbados through intentional collaboration. So as you may guess it from the introduction, this project is near and dear to my heart since I am a Barbadian. But I also witnessed firsthand how the barriers to genetic testing led to delayed diagnoses. And even now, individuals that I saw more than a decade ago are still waiting for confirmation of suspicion on genetic disorders. So we talk a little bit about the center which we recruit individuals from. I hope that this will be me taking you on a journey through the conception of the project and through to the results and the impact of the results, and hopefully the future impact that they will have. Okay, so these are the objectives. Firstly, I'll start you guys off with looking at where we are at in the Caribbean and where we are going. We'll focus a bit, of course, on Barbados. Then I'll talk about the practical challenges in designing and conducting rare disease research within an underserved population, mainly so on the challenges that I encountered and the challenges that I had perceived or thought I would have encountered. And then we'll discuss how intentional research collaborations can shorten the diagnostic odyssey and inform genomic healthcare implementation in underserved and underrepresented populations. So I'll start for geneticists or people within the genetic sphere. This is a very basic sentence. We know that advances in genetic testing have not translated into equitable access globally. And we hear this a lot, but for some, it does not really hit home because they may not be in a place where they have challenges to access. So here in the USA, which is a high-income country, such as maybe other countries like Canada and the United Kingdom, they dominate the landscape of genetic testing, infrastructure, research, and clinical services. And although there may be little pockets in countries with these that still dominate the landscape, because they're rural or remote communities and indigenous and marginalized populations, we know that middle to low income countries and even some high income countries often lack basic genetic services, trained personnel, and regulatory frameworks. So you're kind of at two opposite ends of the spectrum. And this is where the Caribbean lands, on the opposite end of where the USA sits. So firstly, the genetic landscape in the Caribbean. I think I've just given you a hint to where we'll be going with this. But I really wanted to pull and to show you guys a representation. This is an older paper, sure, nearly 10 years old, 2017, and it was the International Rare Diseases Research Consortium. And they were looking to show involvement globally. And of course, there are many countries that are not involved, but here is where the Caribbean sits. And there's not a speck of red. You can try to zoom this as much as you can. You won't find any red. Trust me. This is a more recent article. This was from 2022, and the Undiagnosed Rare Diseases Network International have published this one. And here, just let me get. Again, here is the Caribbean. You may see a little speck of purple. And I was actually a bit excited about this article because it said the Caribbean was mentioned. But what really was mentioned, the Caribbean was attached to Latin America. And usually the Caribbean is always attached to Latin America. But Latin America is the one that drives the advances, especially in the genetics area. So there may be a hint of purple here, but what I'm trying to get is that throughout, regardless of what organizations, consortium that look at rare disease research, that even looks at genetics, typically the Caribbean is not represented. I must say, we may have some representation in biobanks globally, maybe like the UK Biobank, but typically we are not there. So yes, the Caribbean is not represented, but how about the progress? How far have we gotten? So back in 2021, I had the opportunity, I joined up with a group called H3E Caribbean. And if you guys know about H3 Africa, they were trying to similarly do something where they get investment and try to build capacity for genetics research within the Caribbean. What I was tasked to do back then, I was supposed to look and see where we have gotten the progress of where we are for genetic testing, genetic resources with as a region. It was mainly specific to the English-speaking Caribbean, but in general, I looked at every literature or piece of literature that came out of the Caribbean that I can find. Can anyone guess how many literature articles I found? You can just throw it out there. I got 2. 1. I mean, they're a bit more. They're a bit more. I found roughly 100. And even if I'm underestimating that, even if you double or if you triple that, that is still vastly low compared to places like the US, Canada, the United Kingdom. And out of those 100 articles, more than 70% was not from the English-speaking Caribbean. And that's because so before I get to why that may be, this is the Caribbean. For those who may not be aware, there are nice island chains that start from maybe Cuba, Bahamas, and come all the way down to Trinidad. And there are other countries that are maybe landlocked within South America and Central America, like Belize, Guyana, and Suriname. They're actually culturally Caribbean, but these are not represented here. And as you can see, the populations differ vastly. Cuba has quite a big population, Haiti, Dominican Republic, but then we have pretty small islands that have much smaller populations. Together, the population is roughly 40 million, between maybe 40 to 50 million, which is still a quite populous region. So when I thought about formalized genetic services and what I could find, it was within Cuba, who tends to have their own healthcare system, and they tend to do a bit more. Dominican Republic and Puerto Rico, which is a US overseas territory. Cayman Islands have some services, and then you have Bahamas, Trinidad have some degree of services, and then the Dutch Caribbean. And they're overseas territory of the Netherlands. So what they have is an arrangement where a visiting geneticist would come to the islands and then they would send genetic testing to the Netherlands. So they access testing through there. So the Bahamas and Trinidad has some limited capacity. I had the opportunity to chat with a clinical scientist from the UK. She works in the GC capacity in Trinidad. And she says, well, there are really no formalized services. She kind of does this ad hoc. People will send her referrals and she would try to sort out genetic testing and maybe do some genetic counseling if needed. And it doesn't need to be in Trinidad. She's referred as a by the mouth referral, if anything. But we do have some, just not a lot. So that is formalized genetic services. How about companies and institutes? Apart from the ones that I had mentioned, for instance, like Cuba and the Dominican Republic and Puerto Rico, these are what are others within the other parts of the Caribbean that didn't have services, formalized services. So some of these companies, and I just took companies that said, I'll offer some degree of genetic testing. So this could be from one test to as many tests as you can find. So I'm going to talk about, or just mention 3 companies. So Carigen, they're pretty old. They're around quite a while, and they did forensic and relationship testing. And they also have moved over to prenatal testing. But one thing to note that this is actually not done on the island. It's sent out to the USA. Carigenetics, this is a newer company, and they do wellness DNA testing, pharmacogenomics, and research. And they're really making a bigger splash in the research realm than more so at this time, a bigger push in the research realm than the clinical realm. And then I found this interesting company that I got really excited about because they're offering quite a good testing menu for anyone who works in genetics, but they also do send out most of their testing. It's not done on the island. And I just wanted to compare that to here at Mayo. This is just a snapshot of our homepage from the clinical test catalog for the genetics homepage. And it says we offer over roughly 260 molecular genetic tests. And this is just one institution, and there are many institutions all over the USA that offer maybe very small or much more tests. Well, The male tends to be at the top of the amount of tests we ordered, but there's this huge range in the USA, and they're kind of spoiled for choice compared to back in the Caribbean, where you have few companies doing maybe one or two things, and they're all sending them, or most of them are being sent to other countries such as here. So this paper in 2022 really summed it up pretty well. The genetics in the Caribbean, we have limited infrastructure, limited large-scale genomic projects, limited funding, limited access to diagnostic genetic services, and there's a limited level of genetic and genomic literacy. And this is not just among the population-specific general population, but this is even among specialties, the healthcare system. So I wrap this up to say most of the Caribbean exists in a genomic blind spot. However, I do have good news. That is changing. So chatting with Dr. Karika Weldon, who is from Cari Genetics, and she launched the company. She also have launched this Caribbean Genome Project, which is an aim to sequence 100,000 individuals by the end of 2027. However, she has visited other islands to determine the capacity they have, the interest they have for building out their genetic research and their clinical genetics. And we also still have the H3E Caribbean that's still working to push genetics, the area of genetics. So it's changing, but it's changing slowly. So Barbados in genetics. So we aren't any different from most of the rest of the Caribbean. We have limited infrastructure, limited large-scale genomic projects, limited funding, limited access to diagnostic genetic services, and a limited level of our lower level of genetic and genomic literacy. And the project that I'm going to spend the rest of the time talking about, we're going to be looking at this access to diagnostic genetic services within the Barbadian population. So this is where Barbados is. If you didn't know, we are kind of all the way out at the east outside of the island chain a bit. I usually joke and tell people our name takes up more space than the landmass we actually have on the map. And growing up in Barbados, they'll tell you, oh, we are a dot on the map. And I mean, you can say that for most of the islands, but we are pretty tiny with a population of roughly 286,000. And even from 2017, this hasn't changed much. So within the Barbadian context, we have a national healthcare system or service. There is a private sector where people can opt in to pay for, but I'll be more focused on the national health service. So genetic testing is not routine. And there are no medical genetic human resources. So you don't have a medical geneticist, there are no genetic counselors, there's no one that probably has done any more specialty training in genetics. So access for someone to be, say, diagnosed with a genetic disorder, it has to be either a very, very identifiable genetic disorder like Down syndrome, or a specialist, whether that's a primary care doctor or your pediatrician, has to be suspicious that they may be dealing with a genetic disorder. And you could understand if you've done most of your training in the Caribbean where genetics isn't pushed as much, it may be a bit difficult for a genetic disorder to ping on your radar. Okay, so it did ping on the radar, so how do you confirm it? Genetic testing is not available in the local system, so what happens is that you have to write to the hospital and justify why you need this testing. So few people actually receive testing through the public system, and this could be that doctors may not know what to order, or it could be that they're scared to order something that could be wrong, or it could be that it was declined, or they just don't have the budget to actually do the test. Because as you can imagine, a bigger national healthcare system, things like more chronic diseases that are affecting more of the population, more of the budget would be going to. So for those that don't get testing through the public system, they will have to pay out of pocket. So individuals and families often have a possible working diagnosis, and the genetic landscape of rare disease is unknown. However, the research landscape is starting to emerge mainly within that chronic disease area, but it's usually through collaboration, say, with US institutions. So I just wanted to see what articles I could find that had a deliberate Barbadian population that they were looking maybe for a rare disease. And can anyone guess how many I found? You can just shout them out. Don't be scared. 1. Any more? 20. Any more takers? Okay, no more takers. So I actually found 2. So this is the first one. Cuckoo and flying fish and a whole exome, please. And you can tell this is very Barbadian because cuckoo and flying fish is our national dish. Ooh. The first author on this paper is Dr. Scanterbury. He's actually a Barbadian Canadian, and he's a visiting neurologist that actually comes to the center that I recruited our patients from. And he helps, so I think he comes every few months to see individuals that help treat individuals. And they had 5 patients within this paper. Another one I found is Caribbean, but it had a designated Barbadian cohort, and they were looking for a pathogenic variants among adults with breast and ovarian cancer. So these are the 2 I found. And maybe in the next few months or next few years, there'll be more coming out, as I know there are things on the horizon. But at this point, this is just driving home how far we are compared to other parts of the world. So this brings me to the project Intentional Research Collaboration. And I just use the word intentional because for this project particularly, I could probably use any set of available samples because what we were doing was comparing 2 machines, and I'll talk about how the conception of the project, but I really wanted to be intentional that I'll be using Barbadian populations for this project. And sometimes even when we think of individuals or populations that are underrepresented or underserved, maybe there are many opportunities where we can actually give people access through research. If you just think a bit more, instead of using maybe what is easily or readily available, but more going the extra mile to use populations or samples within a group that, it may be more difficult to access. Okay, so the title of the research was The Promise of Cost-Efficient Whole Genome Sequencing, a comparative study of the UG100 versus NovaSeq 6000 for rare genetic diseases in underrepresented populations. And the hope for this project was to solve diagnostic odysseys, promote awareness, genetic and genomic literacy when I take back the results to Barbados, help to understand a little bit of the rare disease landscape, and hopefully attract funding and governmental investment. So that we can get on the same page, I'll just go through a bit of the basics of when we think about whole genome sequencing or sequencing in general. So sequencing could be divided up in generations. So we have first generation, next generation, or second generation. Then we also have this third generation where the technology I'll be using is smack dab here in second generation or next generation. And we have different companies that use different platforms. So here at Mayo, we use Illumina, and the other machine or the other platform that I'll be talking about for the project was from the Ultima Genomics group, and their platform was the UG100. So when we think of next generation sequencing, we can deviate up also into targeted gene panels, exome sequencing, and genome sequencing. It moves from smaller to bigger. And here we are at, for this project, we were talking about genome sequencing. I'll also mention exome sequencing in the next slide, but for exomes, we are looking at the entire coding region of the genome. Well, for genome, we are looking at the entire genome. I wouldn't pay much attention now to the turnaround times because now we have rapid and ultra rapid genomes, but usually a genome takes longer than the other 2. So why are we interested in exomes and genomes, or whole exome sequencing and whole genome sequencing? Because it's considered a first tier test for individuals with congenital anomalies, developmental delay, and intellectual disability. However, remember the title of my presentation was low cost. And why we get excited about low cost is because whole exome sequencing and whole genome sequencing is still costly. So depending on where you are, that can run anywhere between, maybe a clinical genome could run anywhere between, I don't know, maybe 3,000, 5,000, maybe more. It was hard to actually nail this down. But what I'm just saying, it's pricey. It's not a couple $100s. It's more like a couple thousand or more dollars. Now, it's costly for individuals in the US, but then when we translate this to other Caribbean islands, we know that $1 in the US is not $1 for whatever currency that is. So it's not a one-to-one conversion. So for instance, Barbados, if I have $1, then I have 2 Barbadian dollars. So the actual price of that genome is double the price for me in Barbados. Now, it wouldn't be too bad if the conversion for the salaries were similarly. So if you were working for 5,000 US dollars and I was working for 10,000 Beijing dollars, it's comparable. But that isn't the case. See, the median salaries are usually much lower when you have these bigger conversion rates. So that means the testing is much more expensive for someone living in someplace else where, say, the genome is costing 10,000 Barbadian dollars, but you're only working for between maybe 1,000 to 2,000 a month. This becomes a choice of, do I order this testing? And become governments decide how much they can afford to cover, how much they will not cover, and things like that. So anything that brings down costs, we get excited about. So the UG100 sequencing platform, I know for the genetics peoples in the room that most of the cost is not the sequencing, but anything that brings down costs, we get excited about. So the UG100 sequencing platform, they touted a $100 genome. Well, for our current platforms within the clinical setting, here we use the Illumina, we have the NovaSeq 6000, which the project was on, is a $650. So that is $550 difference. The NovaSeq Express is a bit cheaper, so the cost differential is less, but this one was supposed to be cheaper. And as I said, once you start to bring down costs, it helps increase accessibility for this first-year testing. So the aim of my project was to perform a pilot study with 30 samples or less of the performance indices and costs associated with using the UG100 for whole genome sequencing of underserved underrepresentations, and wanted individuals with a known or suspected rare hereditary disorder. And one thing that I really wanted to do was give patients and families a diagnosis. So I did say I'll talk about the concept of how this started. So the ADL, they called for funding proposals. One of the things the ADL, or the Advanced Diagnostic Laboratory, does is actually test new platforms or new machinery before they come into clinical use. So then they call for individuals to, get some applications to see how well this machine at this time was the UG100. So I wasn't the only one. So this has been tested through different projects. So I'll be talking a little bit of more specific to my project when we get to more the indices and what we got. But this is going to be short for just based on the time and what more I have to present. But if anyone have questions about the specific performance for my project, you can ask me afterwards. Okay, so we got the funding. We have to start the project. So IRB approvals, the first thing you have to think about, we can't be doing research without getting ethical approval. And Mayo Clinic here, we got approvals in 2 to 3 months. Barbados took 10 months. And this was actually the biggest hurdle getting the project off the ground. And this was because the site I wanted to use was under the umbrella of the Ministry of Health and Wellness. My collaborators thought they needed approval through this tier of approval. But when we went, they said, nope, you actually need to go to the IRB at the University of the West Indies, and you have to get their approval before you can get our approval. This one took 9 months, and it was just because of a little back and forth of this is not a routine project that passes through IRB approval in Barbados. And it took a bit for all of us to get on the same page. At one point, I just set a meeting with the chairman, and we discussed it out just to make sure that we could get it sped up. And now I've learned my lesson. Before you have projects like this, that may be a bit different, maybe not as familiar with maybe a country or a population that does this sort of genetics, maybe have a conversation with the IRB people before actually submitting it. And if I had to go back, I probably would have done that first. But once we got that, the Ministry of Health and Wellness approval took a month, and then we were off to the races. So the consent samples and sample receipts here at Mayo. So we're back in Barbados, getting all these consents, getting all these samples, and I had a ton of perceived challenges. Now, being from research where we actually had to coordinate shipping samples and receiving samples, everyone knows that could be a bit of a headache, especially when you get a call, your sample is stuck in customs, and you need it before, the time has passed to do the testing. So these were some of my perceived challenges, but Actually, this was the quickest part of the study. Once we got the approval, our collaborators told me I can send you samples by the next week. And this is just to highlight having that relationship with the collaborators and the population that you'll be doing whatever research you'll be doing. I had a pretty good relationship with them. I hadn't worked with them for a while, but every time I go home, I actually go and say, hi, how are you doing? How's the genetics things coming along? And they were really, really excited when I had reached out and talked about the possibility of this project. So I had to tell them, hold on, because we just need to make sure everything is in place before we actually got started. So what they did, they closed their clinics for routine appointments for Monday and Tuesday, and they just brought inpatients, got the signed consents, they did the blood draws, and over a 2-day period, they sent the samples in 2 batches. Happy there were no issues with getting the samples here, went through customs pretty good, and they sent samples today, we got them tomorrow. So that was pretty streamlined. But as I said, remember, watch out for these things because it isn't always as smooth. Zin would know this because her samples had a bit more issues when she was bringing them here. Zin is just my other colleague who was doing a similar, somewhat of a related project. So recruitment of individuals. I told you guys we don't have formalized genetic services, so where are we getting these individuals from? So the Albert Cecil Graham Development Center. And this center was created in 1984, and it was created to evaluate and treat children with developmental disabilities. Actually, when I trained back in medical school, we still called it the Children's Development Center, but it was sort of a misnomer because they were adults. So most of those children who started early at the center actually have been continued to be seen right through adulthood. So we have specialists, we have a developmental pediatrician, a general practitioner, occupational therapist, physiotherapist, other therapists and other specialties, say like our visiting neurologist from Canada, orthopedic surgeon, and psychiatrists who would come in on a semi-regular basis to see other individuals. It does have other units for individuals who may not be able to go to quote-unquote mainstream school, and it evaluates and treats more than 5,000 persons, and it has an average of 130 to 190 new referrals each year. Because this is the only development center on the island, most individuals with developmental issues should pass through this center. And even if they don't, we have one developmental pediatrician on the island, so she should either see them in the public setting or the private setting. So she would have a good pulse on what is going on or who would more likely to need genetic testing. So I just told them, give me 30 individuals, and they made their own inclusion criteria and exclusion criteria, but they were looking for individuals with, as expected, with neurodevelopmental phenotypes, dysmorphic features, either having a clinical complex course, higher suspicion of a genetic etiology, and a working diagnosis needing confirmation. So exclusion criteria, as you would expect, would be if they had previous positive genetic testing and Down syndrome individuals, and they had roughly 60 individuals that were considered for participation across multiple age ranges. However, we could only take 30, so they had to whittle that down. Even months in, they were like, can't we send a few more patients? Unfortunately, we just had the funding for the 30. So the patient cohort characteristics. So we had 21 males, 9 females, and I was happy to see they got a big range of individuals. So from 3 years to 39 years of age. So we had 9 individuals over 18 years, 6 individuals between 11 to 17 years, and 15 individuals 10 years and under. And there were suspected diagnoses were noted for 14 patients. This was more so, as you would expect, a genetic testing naive cohort. So only 2 individuals had previous genetic testing. 2 patients, well, yes, in two individuals had previous negative genetic testing. One had a chromosomal microarray and the other one had a karyotype. Okay, so once we got the samples, what we did, we sequenced them both on the UG100, which was a new technology, and then we also sequenced them on the NovaSeq 6000, which is the platform that we use for our clinical whole genome sequencing. So we were looking at some comparisons such as samples. Well, for this one, we just used DNA from blood samples. DNA input was that comparable. We found that ADL realized a good sweet spot was a bit more than what we would have used in our clinical pipeline. And the turnaround times were sort of comparable. It just depends on how many samples you were running, especially based on with our clinical genomes that from, yes, on the NovaSeq that just have a range. So all of these have a range, but they were within what acceptable comparable to each other. So remember when I talked about the short resequencing and the long resequencing, we're in short resequencing. The NovaSeq 6000, which we use in clinical, has 150 base pair reads. The UG100 gave us a little more, 250 base pair read length, which they had said you would achieve. However, at the time or within my project, this did not translate to increase or better yield or anything extra. Maybe it would for some other projects, just not for my project. So when we think about clinical genomes, we are hoping to achieve a 30x coverage. And the UG100 achieved that also. We knew that our clinical test was achieving that. So the take-home message was that the UG100 showed comparable accuracy to the NovaSeq 6000 for these this is different types of variation that we see in testing. So single nucleotide variants, insertions, deletions, and copy number variations. However, the caveat here is using the predefined high confidence region by the UG100. Our Ultima Genomics predefined this region. So there are parts of our genome that we just aren't good at analyzing. And different platforms will tell you, okay, well, this part, if you just look at these parts of the genome, you'll get pretty good accuracy. Outside of these parts, it may not be that great. So this is what they mean by this is what I mean by high confidence region. We found that there was a drop off in comparable accuracy when we went outside those regions. But they did tell us that it will not perform as well within these regions. Now, the only thing as when you relate to a new technology are those regions clinically relevant? We didn't get into that for this project, but that is something that you would have to also look at. So can we detect the clinical relevant variants in the Ultima data? So we used the data from the clinical pipeline as our true set for the variants that we can detect. And the clinical relevant ones, yes, we can detect them in the Ultima data. Okay, so let's talk about the impact of our results. This would be the largest rare disease cohort in a Barbadian population. And although it's 30 people, that is still much better than 5 people. Not saying that the 5 people that they did in that last paper was too minimal or they did what they have. And I'm happy that they actually took the time to publish that data, because I find that even talking with people back in the Caribbean, they aren't publishing the data that they have. So I'm happy that they did. The diagnostic rate was 63%, which is pretty good. And we had 18 unique genetic disorders. The average years to diagnosis was 13 years. So I've divided up the findings into primary findings, incidental findings, and secondary findings. So our primary findings, we had some autosomal dominant disorders, X-linked disorders, autosomal recessive disorders, microdeletion and microduplication disorders, and we have some an unbalanced translocation. So most of these disorders were just seen in one individual. However, Angelman syndrome and Williams syndrome was seen in 2 individuals. So some of these disorders, some people would recognize maybe Fragile X, maybe Angelman, even Williams syndrome. But then there were others that I didn't even myself recognize. This was the first time I heard about the syndrome, and they actually popped up when I was analyzing. So we do have, it seems we do have a wide range of, and expected a wide range of rare diseases that no one knew or may have even thought to look at in the cohort in Barbados. So secondary findings. Secondary findings, these are results from a genetic test revealing medical information that is unrelated to the original reason the test was performed. So the American College of Medical Genetics, they have a list, and this list is related to genes and related disorders where you can where there's an actionable thing to do. There's something you can do, either there's increased screening, you can better manage, there's something that you can do. And all of the participants opted in to learn about secondary findings. So we had 2 individuals with secondary findings. They were all hereditary cancer syndromes. The first was, I believe it was a female who had a variant that would cause Lynch syndrome. This individual did not have much family history. Our second individual, they had an APC variant that is associated with polyposis conditions like colorectal cancer. Think of that. And when we got this, the clinical history for this individual, all it said was 10-year-old male, really neurodevelopmental phenotypes. We didn't get a family history of cancer. However, once we saw this finding, we gave it back because it's one of these, you probably need to start screening pretty soon, teenage years, or as to capture the individuals early so that you can know what to do. And this was the family history we got back. So we found that mom had actually passed away in her 20s. She had an uncle who passed away in his 30s. And then you had other family members. So it was a strong family history of cancer. And this family has seemed to have slipped through the cracks because no one was thinking about getting screening earlier. This individual had siblings who were at the age where screening should have been performed, even if they didn't get genetic testing, because we know that genetic testing isn't really accessible, but at least they could have gotten, their colonoscopies would have been 10 years earlier than the diagnosis of their first degree relative, which was mom, who was diagnosed at 27. So incidental findings. So these are results from a genetic test revealing medical information that is unrelated to the original reason the test was performed. So for secondary findings, we really go and look for these. These are ones we aren't looking for, and they just happen. And they've just popped up when we are analyzing them, I should say. So we had 4 males with G6PD variants. This probably was expected because we have 90% of the population is of African ancestry. However, we actually do not track this. So we actually don't know the prevalence of G6PD on the island. We had 1 individual with a mitochondrial variant that causes hearing loss following aminoglycoside exposure and even hearing loss as you age. And then there was 1 individual who had a high percentage of combined regions of homozygosity. And what this just means that there was it seems or appears that the parents of this individual were related. We also had individuals who had, I call them, potential to be solved. And the reason why we can't solve them is we don't have enough evidence for the variants that they have. They may need either more work, especially for this intronic deletion, maybe RNA studies to show that the deletion actually is causing something or doing something. But these are pretty good candidates that we could get individuals enrolled in other studies. We also could get individuals get more testing done if we have more funding. And I know that sometimes we just hear results, but we don't see the impact of these results on patients and their families. And I haven't talked to these individuals, but I kind of know some of their journey from seeing at least 2 of them years ago in the clinic. So the first is a 17-year-old male. At the time, he probably was younger than 7 when I saw him. He presented at around 9 months of age at the center, and he had developmental delay, severe myopia with some eye findings. And he was one of the few that had a karyotype back then, and it was negative. So back then, most of what you would see for any genetic testing was a karyotype. I remember advocating and saying, if you don't do a karyotype, because at the point in time, microarray was what was the first year. I'm not sure if they moved towards that, but we did see someone had a negative karyotype in this group. So hopefully they did. But back to this patient, the clinical course was suggestive of Angelman syndrome. So because we don't have resources on the island, sometimes some families have the resources to take their children elsewhere. So this child got the chance to go to the USA at a different institution, not here at Mayo, a different institution, and the specialist did not agree with the diagnosis. Granted, the specialist is only seeing that person for one time, have a limited history, and they are given the opportunity to really see that person again because the family went back to Barbados and never went back. Because you can see that it would be an expensive journey to keep going back if you have to be followed up by a specialist in the USA. However, the developmental pediatrician was very adamant that this was Angelman syndrome. And we were happy to see that we did find a variant that would explain the Angelman syndrome diagnosis. So talking to this family all those years ago, they just really wanted to clarify, what does my kid have? One person says one thing, but the specialist is saying something else. And here we have some clarification for that family. Our second patient, our second participant, currently now he's a 16-year-old male, and he was referred to the center with congenital rubella syndrome because of the striking findings that he had. This is not the patient. We don't have permission to show photographs, but he looks like him. And I remember sitting with the mom, and I was taking the history and the power of just having a short history. And I said, well, you know, you ask the same questions you ask all the time. And many times you get the answer, no, no one in my family has this. But then mom said, oh, yes, I had a brother who died pretty young, who looked exactly like him. And my mom said he was the spitting image. And from that, I was like, okay, well, it probably is. It's most likely not congenital rubella syndrome. And back then, you do a quick Google. I was an eager medical student, no genetics background. So I Googled it, and Lowe syndrome popped up. And this was the provisional diagnosis because it really fit. And this is what Lowe syndrome individual looked like. And he looked like him. So I said, well, it probably is Lowe syndrome. And we were able to find a variant in this gene, OCRL, that does cause Lowe syndrome for this individual. Our last patient, this is a 22-year-old male. I did not meet him when I was doing my rounds at the center, but he had a Fragile X diagnosis that they were wanting to confirm. They thought he had Fragile X, but as I said, one of the things talking to the developmental pediatrician and the other doctors is that because we don't have genetics expertise, we're just given these query diagnoses, but we really aren't sure, and we would like it to be confirmed. So we did get a confirmation of Fragile X, and after confirming the Fragile X with our assay here in-house, they realized that they had other clients of the center who were family to this individual, especially this little boy would be at risk, and even the girl would be at risk also for Fragile X. So they would continue to see if they can get testing done in these other individuals. Okay, so back to the impact of work and future directions. So as I said, this is the largest cohort to date describing genetic testing in a Barbadian rare disease cohort. Individuals and families will receive a diagnosis. The UG100, the platform, it detected most of the clinically relevant variants and could be a potential low-cost alternative if needed. But one thing that was striking was that the diagnostic odyssey the average years to diagnosis was 13 years. And looking at what is quoted for diagnostic odyssey, this is roughly 2 to 3 times longer than you would expect if these individuals were in a place that had access to genetic testing. We know that some of these individuals, if they had access, they would have been diagnosed years ago, and families would have had the opportunity to do family planning. They wouldn't be wondering for years, what does my kid have? So this finding highlights how, limited access to genomic testing results in diagnostic silence, missed opportunities, appropriate treatment, effective management, and informed family planning. And while universal genome sequencing remains maybe financially unrealistic, we can't sequence at this point everyone in the Caribbean with intellectual disability with the National Healthcare Service. But because of the high yield of the phenotypic criteria that they use, maybe this could be how they start. These are the individuals who we use sequence. It offers a practical approach for expanding access, but it also offers an approach for individuals to see why this is beneficial. Because if they aren't seeing the benefits of it within the community, they probably aren't going to be that interested in investing in it. Also, inform the framework for genetic testing prioritization. Who gets tested? What testing should we offer? Maybe instead of doing other testing, we go straight to the whole genome sequencing. But we'll see, it's more of a discussion. But advocacy for governmental investment. And the government has started to invest more in the research, just not really within diagnostic services. We do have a living laboratory in Barbados that opened, I believe, last year, summer, and they're hoping to do some sequencing on a research basis. They started with viruses, though, so I don't know how long it'll take us to get to humans, but hopefully rather soon. Also, advocacy for genetic and genomic literacy, and also advocacy for national development initiatives. I know Barbados has a national development call where they put things that they need and they send individuals overseas to study and come back to the island so that they can benefit the island. Okay, so I'm bringing it right back to the Caribbean. Now, we've seen this small project, and it's just a small drop in the bucket of where we'll need to go. But when we're thinking of building capacity in the Caribbean, some of the things we need to consider are like populations. So sometimes people may be a bit, I won't say surprised, but they sometimes don't know that the Caribbean is actually quite diverse. If we take a look at Barbados, it looks vastly different demographically to Trinidad. So Barbados is more than 90% of African descent. Trinidad, a third of their population is East Indian. And then you have a third that is mixed and a third that is Afro-Caribbean. So from different islands to islands, you have different populations, demographics. And that's something you'll have to think about. We aren't all the same, just like here is diverse, the Caribbean is very diverse also. Accessibility and sustainability. So sustainability, because genetic investment is actually not cheap. But we do only have some populations that are, say, Barbados is pretty tiny, Dominica is tiny. How will they be able to sustain such if they have such a big investment? Does it mean we have to come together more? Does it mean we'll have to have labs in different places? It's just things to consider. How will that happen? And of course, accessibility. If we go have something in Barbados, how will someone from Anguilla get it? Are we going, things like that. And also the local context. For instance, Bahamas, there was an article noting that they had found a variant for BRCA and BRCA1. And that we may not see in Barbados. Should we make sure we are testing for this variance in people who may be in Bahamas versus maybe other variants as first-tier testing, just to make sure we're covering our bases first before we go to more other sequencing or other testing. And regulatory oversight. Because we haven't expanded so far within the area of genetics, we don't have the regulation, and the regulatory oversight will be needed to ensure high quality research, to ensure high quality diagnostics is being offered and being done within the region. So lastly, why do we care? Okay, so that was nice. It's in the Caribbean, but why do we care? Because I'm here in the US, or how is that beneficial? So representation improves healthcare disparities. As I said, Barbadians just don't sit in Barbados. I'm here, and many of us travel all over the world. You probably will meet, maybe Jamaicans are a bit more prolific, and I always meet a Jamaican wherever I go. So we travel, people migrate. And when we think of how historically genetics was done, it was on European populations. So we have those disparities still occurring, and we really need representation. Of course, it improves precision medicine, which feeds into the first and also the next one I'll talk about. But it improves our ability to understand genetic impact on diseases. Sometimes those missing links could be other populations. And also help building global partnerships. So research collaborations like this now, they know that, okay, Mayo does all of this testing, we can send something to Mayo. Or it also knows that, well, we had some individuals here at Mayo that was involved in this project. Let's reach out and see how we can build something else. So the project isn't just, sure, it's about building capacity in Barbados, but genetics and doing genomics is a global thing. And we are trying to get global equity. And these projects such as these are small moves, are independent. I think it's a big move, but that's just me into the right direction. So with that, I want to say thank you and acknowledge Dr. Sazri, who was the consultant proponent for this project, Dr. Stander, Dr. Bozak, Dr. Maraku, individuals at the Albert Greek Cecil Graham Development Center, Nisha Whitehead, she's actually an occupational therapist. Dr. Jennifer Campbell is the developmental pediatrician. Dr. Paula Michelle Lashley, she is a lecturer at the University of West Indies. And Dr. Gail Medford is also a pediatrician at the center. And of course, all the Barbadian participants and families. The clinical genome sequencing laboratory, Heidi, and the advanced diagnostic laboratory, of course, for the funding, and also Joseph and Vivek, who really did a lot of the work on the samples and the ultimate genomic support team. Thank you.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.